Emergency Department Triage Nurse. Before any physician sees you in the emergency room, the hospital's always open door for injuries and sudden illness. Someone has to decide how dangerous your wait is. They take vital signs, ask a brief history, and assign an urgency level, often using a 5-level system called the Emergency Severity Index, adopted in emergency departments across the United States to sort millions of visits every year. Chest pain, stroke signs, trouble breathing. The triage nurse catches red flags and escalates immediately, while less urgent cases wait safely behind life-threatening ones. The word triage comes from the French trier, to sort, a practice born in battlefield medicine. Now the reason a broken finger and a heart attack can share the same waiting room without sharing the same risk. Without triage, care would follow arrival order, not medical need. Once urgency is set, the hospital still needs to know who you are before anything clinical can be ordered. Patient Registration Specialist. They open your chart, verify your identity, capture insurance and consent, and create the electronic record every other department depends on. A physician cannot legally order a blood test, assign a bed, or schedule surgery for someone who is not registered in the system. Registration clerks work inside platforms like Epic, one of the most widely used hospital record systems in the United States, the step that attaches every lab result, scan, and medication order to the correct human being. At the emergency room desk, this often happens under time pressure, wristband printed, chart open, handoff to clinical staff. Invisible when it works, catastrophic when it fails. With the record open, physicians can order tests, but someone has to collect the samples. Phlebotomist. They draw blood and collect other specimens, samples from the body sent to the lab, label every tube at the bedside, and deliver them to the laboratory so physicians can diagnose and monitor treatment. They confirm identity with 2 identifiers, name and date of birth, because a mislabeled tube can send the wrong results to the wrong patient. A huge share of medical decisions depend on what is in the blood: infection, whether the blood is carrying enough oxygen, kidney function, heart attack markers. If the sample is never drawn from the wrong person, or mislabeled, the entire diagnostic chain breaks. The American Red Cross runs blood drives across the country. Donation chair, tourniquet, the tight band on the arm that makes the vein easier to find, labeled tubes, the most public face of the same blood draw skill hospital phlebotomists use on inpatients every day. Blood work is one window, imaging is another, and someone must run the machines. Radiologic technologist. They operate the imaging equipment, X-ray, CT, MRI, position the patient precisely, and produce the scans radiologists and physicians interpret. Physicians cannot treat what they cannot see. The technologist is the person who actually makes the image. They follow radiation safety protocols, screen patients for MRI safety. Metal and implants can be dangerous in a powerful magnet, and send finished images to the hospital's picture archiving system for physician review. Godfrey Hounsfield developed the first CT scanner. His invention transformed diagnosis and created the modern imaging department technologists run today. Work the Nobel Prize recognized in 1979. Results return to the chart, but someone must watch the patient between physician visits. Staff nurse. On the hospital floor, the bedside nurse is the continuous human presence, assessing pain, breathing, mental status, administering medications, and responding when call lights and alarms go off. Physicians round on schedules, minutes per patient per day. The staff nurse holds the entire shift together. They document in real time, coordinate with pharmacists and therapists, educate families, and advocate when something changes. Florence Nightingale showed the world that trained nurses and clean conditions save lives, professionalizing modern nursing in the 19th century with observation and systematic care principles. Bedside nurses still practice. Medications flow through physician orders, but a pharmacist verifies every one before it reaches the patient. Hospital pharmacist. They review every medication order for interactions, allergies, duplicate therapy, and dosing errors, the last expert checkpoint before a drug reaches a vein or a mouth. They prepare IV medications in the pharmacy clean room, dispense to nursing units, and respond to code situations with drug expertise when emergencies do not wait. Medication errors harm patients. The pharmacist catches mistakes busy physicians and nurses might miss during a chaotic shift. Johns Hopkins Hospital was among the first in the United States to establish a dedicated inpatient pharmacy in the late 19th century, helping define the hospital pharmacist as a clinical safety role, not just a pill counter. Some patients need the operating room, and the OR cannot open without its own team. Surgical technologist. Not every hospital stay includes surgery, but when a procedure is needed, this is the person who makes the operating room possible. They set up instruments and drapes, maintain a sterile field throughout the case, hand tools to the surgeon, and count sponges and needles before and after. Any break in sterility risks infection. Surgery is a team performance. The surgeon depends on a scrubbed room, correct instruments, and someone anticipating the next step so the procedure does not pause for missing tools. Mayo Clinic is famous for coordinated surgical teams, scrub technologists, nurses, and surgeons training together as integrated operating room units. When care is done, clearance on paper is not enough. Someone must plan the exit. Discharge planner. They bridge the gap between medically ready to leave and actually safe at home, arranging follow-up appointments, home equipment, transport, and support so recovery does not fail at the door. Planning starts early in the stay, not only on the last day. Wound care, mobility aids, skilled nursing or rehab when home is not safe yet, insurance authorization, and warning signs that mean coming back. A patient cleared by a physician may still be unable to climb stairs, afford medications, or reach a follow-up appointment. Hospitals everywhere must plan discharges so patients do not bounce back, turning an empty bed into a real recovery, not just a discharge form. Large urban hospital networks like Mount Sinai in New York coordinate these transitions daily for patients with multiple chronic conditions, case managers and discharge planners working the handoff. The building depends on 1 arrival, 8 jobs, 1 chain of people, each role handing off to the next so the hospital can care for the stranger who comes through the door after you.